Hello, my name is Dr. Erika Hope, and I'm a GYN Oncology Fellow in the Greater Washington, D.C. metro area. Today, I'm going to be talking about endometrial cancer, or cancer of the uterus. Endometrial cancer, or uterine cancer, is the most common gynecologic malignancy. Women in the United States have a 2.6% lifetime risk of developing uterine cancer, or about 1 in every 50 women. To give you a reference, the lifetime risk of breast cancer in women is 1 in every 8 women. The average age of diagnosis is 60 years. 3/4 of women diagnosed with endometrial cancer will be diagnosed at an early stage. It is more common in Caucasian women versus African American women. More than 90% of endometrial cancer originates from the lining of the uterus, called the endometrium, and is termed endometrioid adenocarcinoma. There are multiple different types of endometrial cancer. Endometrioid is the most common type and accounts for more than 90%. Papillary serous and clear cell are less common and are usually more aggressive with a worse prognosis. Sarcomas are cancers of the muscle or soft tissue of the uterus and are relatively rare. This is a figure from Cancer Statistics of 2014 with the estimated new cases and deaths. Endometrial cancer is the 4th most common cancer in women and makes up 6% of the cancers diagnosed in women. However, as you can see from the list on the bottom, it accounts for only 3% of annual cancer deaths, as it is typically diagnosed early in the disease process. The main risk factor for endometrial cancer, again, we are speaking in generalities about the endometrioid endometrial adenocarcinoma, which comprises more than 90% of endometrial cancer, is an excess of estrogen. The risk factors are listed here. Hyperplasia is an overgrowth of cells and can be associated with atypia or abnormal cells. Hyperplasia can be an intermediate between abnormal cells and cancer. Hyperplasia is classified as simple or complex based on the appearance of the glands and is also classified as with or without atypia. Complex hyperplasia with atypia has a risk of underlying cancer of 40 to 60%. Other risk factors include estrogen replacement therapy without the use of progesterone, chronic anovulation as with PCOS, estrogen-producing tumors, obesity, tamoxifen use, diabetes, age, infertility or no prior pregnancies or deliveries, early age of menarche, late age of menopause, family history of Lynch syndrome or hereditary non-polyposis colon cancer or HNPCC, or a history of radiation therapy to the pelvis. Most women are diagnosed after menopause. Only 15% are diagnosed before age 50 and only 5% before age 40. Obese women are 3 times more likely to develop uterine cancer. There are some protective factors against endometrial cancer. They include birth control pills, the injectable birth control Depo-Provera, the progesterone IUD such as Mirena. Abnormal uterine bleeding or vaginal discharge may be a symptom of endometrial cancer and is one of the reasons why endometrial cancer is typically diagnosed early in the disease process. Other symptoms are very nonspecific and may include abdominal or pelvic pain, bloating, feeling full early, called early satiety, or changes in bowel or bladder function. These may be seen in advanced disease, but again also may be present due to other causes. If abnormal uterine bleeding is present, or postmenopausal bleeding is present, your provider will order some tests. An ultrasound, typically a vaginal or pelvic ultrasound, may reveal a thickened lining of the uterus, but the diagnosis of endometrial cancer is made by obtaining a biopsy or a piece of tissue for a pathologist to look at under the microscope. This can be accomplished with a procedure called an endometrial biopsy done in the office, or a dilation or curettage, or DNC. An endometrial biopsy uses a small, thin plastic tube to obtain a tissue sample from inside the uterus. A DNC can be performed in the office or in the operating room and uses a small instrument called a curette to obtain a tissue sample from the lining of the uterus. If symptoms persist, you may require a repeat ultrasound and/or a biopsy. If a cancer is found, the pathologist studies the tissue samples from the uterus under a microscope to learn the grade of the tumor. The grade tells you how much the tumor tissue differs from the normal uterine tissue. It suggests how fast the tumor is likely to grow. Tumors with higher grade grow faster than those with lower grade. Tumors with higher grades are also more likely to spread. Doctors use the tumor grade along with other factors to suggest treatment options. Although most endometrial cancer is diagnosed at an early stage, your provider may order additional tests such as chest x-rays, CT scans or MRIs, or lab tests such as a CA-125 or a pap smear to complete the evaluation, and you may be referred to a GYN oncologist who specializes in gynecologic cancers. Surgery is the most common treatment and evaluation of endometrial cancer and is usually performed by a GYN oncologist. It is also needed in most cases to learn the stage of the cancer. It typically includes removal of the uterus, cervix, or the neck of the uterus, fallopian tubes, and ovaries. Removal of the ovaries will induce menopause if the patient is not already postmenopausal. The surgery may also include removal of lymph nodes in the abdomen and pelvis. Surgery can be individualized based on patients' comorbidities and individual risk factors. The cancer stage is determined after surgery is completed and all of the specimens are reviewed by a pathologist. Based on the stage, this will determine the prognosis and the possible need for additional treatment, called adjuvant treatment. The staging for endometrial cancer is listed here. 3/4 of women will present with either stage 1 or stage 2 disease. Stage 1 is limited to the lining or the muscle of the uterus. Stage 2 involves the cervix or the neck of the uterus. Stage 3 includes the outside lining of the uterus, fallopian tubes, ovaries, vagina, tissue surrounding the uterus, and or the lymph nodes. Stage 4 is distant spread. Stage 1 is divided into stages 1A and 1B. 1A involves only the lining of the uterus, called the endometrium, or less than 1/2 of the myometrium, which is the muscle layer of the uterus. Stage 1B involves 1/2 or more of the myometrium of the uterus. Stage 2 involves spread to the cervical stroma, which is the connective tissue of the cervix, but no spread outside of the uterus. Stage 3 has several divisions. Stage 3A involves the outermost lining of the uterus, called the uterine serosa, or the fallopian tubes, ovaries, or uterine ligaments. Stage 3B involves the vagina or the perimetrium, which is the tissue that surrounds the uterus. Stage 3C is further classified into 1 and 2. 1 involves the lymph nodes in the pelvis, and 2 involves the lymph nodes surrounding the major artery in the body, the aorta. Stage 4A involves spread to the bowel or the bladder wall. Stage 4B is distant spread outside of the pelvis or to the groin lymph nodes. Endometrial cancer is highly curable. The 5-year survival is based on the stage of the disease. The earlier the stage of diagnosis, the better the 5-year survival. If there is distant spread of disease or stage 4, the 5-year survival is 21 to 22%. Your GYN oncologist may recommend radiation therapy and or chemotherapy as additional treatment, called adjuvant treatment. Risk factors include the type of cancer, grade of cancer, cancer stage, your age, and also your general health. If the cancer is diagnosed at a very early stage, some women require no additional treatment besides the initial surgery. Radiation therapy may involve external radiation and also internal radiation that is placed directly into or near the cancer. Other treatments include hormone therapy, biologic therapy, and or targeted therapy. These will be discussed with your provider. There are many issues that patients face after surgery. These may include menopausal symptoms like hot flashes and night sweats after removal of the ovaries, but only if the patient was not postmenopausal before surgery. Some women also experience sexual dysfunction and buildup of fluid in the legs, called lymphedema. Sometimes these can be managed with different therapies and are important to discuss with your GYN oncologist. After surgery and additional treatment for endometrial cancer, there is a period of increased surveillance where your GYN oncologist will see you for more frequent visits. Any new symptoms involving vaginal bleeding, pelvic pain, weight loss, or general lethargy should be discussed with your GYN oncologist. Endometrial cancer typically recurs at the vaginal cuff. The cuff is at the top of the vagina where the cervix was located prior to its removal with the hysterectomy. It is inspected during every follow-up visit for evidence of recurrence. Treatment options for recurrent endometrial cancer are dependent on the location, types, and time since previous treatment, and also the performance status and general health of the patient. Take-home points from today's lecture are: endometrial cancer is the most common gynecologic cancer. More than 90% are endometrioid endometrial adenocarcinomas, or cancers of the lining of the uterus. These are associated with estrogen exposure. They can also be associated with abnormal bleeding or postmenopausal bleeding. This means that they are typically diagnosed at an early stage due to its symptom of vaginal bleeding, and if diagnosed early, can be highly curable. Treatment typically involves surgery and may also include other adjuvant therapy such as radiation and/or chemotherapy. For more information, you can visit these websites: Globe-athon.com, sgo.org, and foundationforwomenscancer.org. Thank you.